Hello and welcome to this webinar which we're recording today, and the focus is on prostate cancer. Very common as a GP, something that you would see quite frequently in your professional life. And although things have changed significantly, certainly over the period of time I've been a GP in terms of the diagnosis and treatment, it always is a concern that it's one of the cancers which is very common, and with the need to bring the diagnosis into stage 1 and 2 to improve the survival. Not only do we need to know a bit about what the modern treatments are, but also about who are the groups that we miss and we diagnose late. And is there anything we could do as GPs to improve the outcome for people with prostate cancer? So today I've got a number of people with me who are going to help me discuss this important area, and then hopefully we can come up with some bits of information that may help you in your clinical practice. So if I go around and ask people to introduce themselves. So Philippa, can you tell us a bit about yourself?
Yeah, thank you, Nigel. I'm Philippa Aslett. I'm a urology specialist nurse, and I've been working in the field of urology and particularly prostate cancer for coming on for 30 years. And I'm currently working with the Alliance as well.
Thanks. Duke, would you like to introduce yourself?
Hello, yes, I am a black British man living in Portsmouth, 58 years of age, and I am the Equality, Diversity, Inclusion Officer for Pompey Community affiliated to Portsmouth Football Club.
And Ed, would you like to introduce yourself?
So yeah, hi, I'm Ed Chedji. I'm one of the consultant urologists in Southampton with a specialist interest in prostate cancer, from the diagnostic end to robotic surgery at the other end, and everything in between. Thank
you. So, when we're sitting there in our practice with, thousands of patients and many male patients, I think we're all pretty clear that prostate cancer is one of the most common cancers. It increases with age. I was once told, and Ed may be able to correct me, that once you reach the age of 100, probably 100% of men have got prostate cancer. We often see prostate cancer in older people that progresses slowly, but then you get it in younger people where it's really quite aggressive, and often picked up at a late stage. Common because it occurs in about 1 in 8 men at some time during their life. Is that right, Ed? Something about that sort of frequency?
Yeah, so I think the latest data, which I sort of looked up today to make sure I was current as possible. So for white men, the numbers are sort of 1 in 8, and actually for black men, it's 1 in 4. So there's double the risk for black men as opposed to white men, which is why we kind of want to raise the awareness of this particular population as being high risk. There's also an increased risk with family history. So, family history of prostate cancer, particularly the BRCA1 and 2 mutations, and indeed Lynch syndrome, all increase your individual risk of having prostate cancer. And actually the risk now has gone up to 140 men every day are diagnosed with prostate cancer. So it's a big problem that I think is unrecognized quite a lot.
So what sort of age do you see the sort of takeoff of increased risk?
So, probably by the age of 70 to 75, as you say, a lot of men in that age group will have prostate cancer. But I guess as a urologist, our job is to sort of work out which are the rabbits and which are the hares, and try and, make sure we catch the cancers that need treating, whilst at the same time avoiding the morbidity of treatment in the men that don't need treating. I think historically we probably have been accused, probably before my times of training, of tackling prostate cancer too aggressively, and these days we've got a much more refined approach to sort of treating and diagnosing prostate cancer, in the hope that we minimize the harms but maximize the benefits from the treatments we've got on offer.
Yeah, I can certainly remember being told that certainly if you pick up prostate cancer early, people weren't really sure what was the best treatment, and sometimes wait and see and monitor was as good as being aggressive with your treatment. Is that still the case?
Yeah, I mean, if you've got a low grade, low risk prostate cancer with stable parameters, then, rather than watch and wait, we do this thing called active surveillance, where we sort of actively monitor the patients to make sure that their cancer doesn't start misbehaving. And we do that with regular scans and potentially biopsies if required. But probably, some in the region of 20 to 40% of men who are newly diagnosed with prostate cancer may be suitable for that. So, there is some benefit in having that diagnosis, in that we can look at those patients and they don't necessarily need treatment, which is great.
So you don't think we should be telling every man over 50 that they should go and get a PSA test on an annual basis?
I probably wouldn't say that. I think the latest evidence suggests that if you have an early PSA in your mid-40s, that gives you the best predictor of potentially developing cancer further down the line, and can risk stratify you into sort of a higher risk and a lower risk. So if you're in your mid-40s and your PSA is less than 1, your lifetime risk of developing prostate cancer is very low. Whereas if it's greater than 1, then that risk goes up. And obviously, there's no specific screening protocol in the UK at the moment, but we are seeing the longer term data from big European studies with sort of 15 to 20 years follow-up is showing that the number needed to screen is significantly going down with that.
So you've just made my day, because I have had a PSA in my late 40s, which was less than 1. So
fingers
I'm
crossed.
personally feeling quite relieved now, thinking of the frequency of 1 in 8, which is actually very common for a cancer. So, okay, so if we're not going to do screening, but the PSA seems to go through sort of cycles of being not a very good test, or it could be a useful test. How do you see the PSA, and also doing rectal examinations on men to detect that hard, knobbly, craggy prostate?
So I think that for me, it's all building up a picture. The PSA is one part of the picture. The DRE is another, if necessary. Some areas suggest that we don't necessarily even need to do that anymore. Basically, because if your PSA suggests you are at risk and you've got risk factors, then most places will then sort of lead to do an MRI scan, which is probably more accurate than the PSA and the DRE put together. But as you add these layers of information, I think that helps you to stratify individuals as to whether they then need to go on and have a biopsy, which will ultimately determine if they have a cancer or not, and what kind of cancer it is.
Okay, so I'll come back to you a bit more about the treatment we offer. Philippa, do you want to ask Duke some questions from his point of view as a potential patient?
Yeah, certainly. So, Duke, perhaps we can just start. You've obviously had a think about having PSA testing, and when we spoke, we talked about perhaps what some of the barriers are for Black African Caribbean men to come forward and have a PSA test, and perhaps you can articulate for us what those barriers are.
Hi, Philippa. I think the main barrier is the DRE, as Ed was saying, and the homophobia around it, that stigma around the homophobia, because 99.9% of Black, Caribbean and African men are homophobic when it comes to the actual examination. And I know in Jamaica they really dislike the gay community. So your life is in danger if you're a gay person, especially in Jamaica. So and hence why a lot of Black men don't go for these examinations, because a lot of the time, I know for me, the barrier was the examination, and I didn't know about the PSA.
So when Ed was talking about the possibility of having sort of direct to PSA testing and perhaps even bypassing a rectal examination, do you think that would encourage men like yourself to go and see their GPs more readily?
Yeah, 100%. And I think the GPs will have to kind of sort of talk to their patients about it before sending them out a letter to tell them to come in for a PSA. So they need to know what they're coming in for, because you'll just pick up a letter, go, right, come in for a prostate PSA. It will scare the life out of them, and half the time they probably won't turn up. So maybe at some point when you are seeing Black Jamaican or Black African men, maybe mention stealthily about the PSA and the process around it, because I know a few years ago I was that guy who would not go for a prostate test because of the examination, and that's all I knew was that examination.
And did you recognise that because you're a Jamaican man, that you were in a higher risk group for prostate cancer, and particularly then if you have a family history of prostate cancer? Do you think that there's an awareness or an understanding in your community that you are a high risk group for this illness?
I had no idea, Philippa. And it was only when I speak to the odd members of family or family friends that we then find out that we are at high risk of blood pressure, diabetes, and prostate cancer. But outside of talking to family members, I had no idea. No idea whatsoever.
Philippa, I think that's a really interesting question, because I mean, you know, when I was as a GP, we had, as times had changed, and we had more and more female doctors who did more and more of the women's health. I saw more and more men with prostate problems, so became quite knowledgeable about it. But it wasn't until I joined the Cancer Alliance that I became quite so aware of the raised incidence in Black Afro-Caribbean men. So I don't think it's just, you know, Duke and his colleagues that may not be aware of it. I do wonder whether actually amongst the GP community they're as aware of it as perhaps we should be.
Yeah, I think you're probably right. I mean, within primary care, we are expecting our GPs to sort of build on so many areas of healthcare, aren't we? And so there is a responsibility for those of us in secondary care, and with the help of the Alliance, to health educate and to educate both our colleagues within primary care and ourselves. And I just wondered, if I may, Duke, what do you think we could do to help educate the Black and African Caribbean population?
It's a big question, Philippa. I think there needs to be more visual campaigning within the doctor's surgeries. I mean, we have visual campaigning on social media, but in the older generation of Black African and Black Caribbean men, not all of them have social media. I don't know. I mean, my dad doesn't have social media, doesn't even know what social media is. And the internet, he just has one of these push button phones, that's it. So I think when I go to my GP surgery, I see nothing in there about Black, Jamaican or African men around prostate cancer, nothing at all. So it's about maybe, again, it's that stealth stuff. Stick a poster on the wall, waiting rooms, wherever you can, whilst you're sitting down waiting. You visually just look around anyway, don't you? So subliminally, you'll pick up the information, but I don't see nothing like that. So it's about hard information, really, not so much around social media, because not everyone's got it, especially at that age. And from experience, a lot of Black men will not go to the doctor's surgery. One, because there are Black men that don't trust white doctors, full stop. Two, there are a lot of Black men or Black families that like to think they can fix that problem with some kind of bush remedy or something like that will cure it. And so we have those factors involved as well. And three, some just are too scared to go to the surgery, or just out of embarrassment, purely out of embarrassment. And that they're one of the things that stops them going. So it's about hard copy campaigns on the wall, talk to them all the time about prostate cancer, making sure that the community has the information. Even it means going visiting community leaders. You know, I visited a city of sanctuary today in Portsmouth, where they have refugees. They look after refugees that come into the country. And I mean, places like that could do with information.
So there's some proactive things that we can do, some of them really quite simple, aren't they? And I guess making all our conversations count, so that we're using the opportunities when we do interact with a patient, and to make that assessment of risk and highlight the areas that are at risk. And for Black African Caribbean men, alongside diabetes and hypertension, is going to be prostate cancer.
Yeah, so every time you see a Black African or Black Jamaican man, give him a leaflet. whether he came in for prostate cancer or not, or just a general overhaul. Just give him a handful of leaflets, not just prostate. Stealth moves. You know, give him a handful.
I think what you say is quite eye-opening and quite important. So I think as doctors, we quite often see investigations through our eyes of somebody's got this, so you need this, without really thinking about patients' resistance, reluctance, fears.
Yeah.
I mean, we were having a bit of a discussion before this about one of the things we were taught as GPs is always look to patients to look at what their ideas, concerns and expectations are. And actually the concerns and expectations are really important, because it's easy to put your own judgment on that. Well, you know, this test is not, you know, we just do this, it's okay, without really thinking why people don't come and see us and what those barriers are. So I think that's one thing that I think is really, really important with what you say. And I think actually explaining to people, giving them that information about what the risks are without making it just alarmist or assuming that if we put messages on social media or some other way, because people get messages in all sorts of different ways, don't they?
Yeah, absolutely. And it's vitally important that we try to remember how to get messages to different people in different ways.
Yeah.
Not just social media. Again, I would just repeat it. It's about hard copies on the wall, in waiting rooms. It's about your doctor giving that knowledge, not just about prostate cancer, giving them leaflets with one inside, just giving them something to read on the process of how to get tested and what it involves.
And it is interesting, isn't it, about the homophobia, because I suspect that, you know, if we are not Black African men, then the reality is we may not have the same feelings and the same concerns. And it's understanding, isn't it, for us to understand that we need to hear what Duke is telling us, so that we can then reach out to Black and African men, and actually perhaps we do say, well, we're not going to do a rectal examination. We are going to do the PSA. We're going to talk to you about your symptoms, and we're going to send you in for a review with one of the consultants at the hospital. I guess it's understanding that, isn't it, and trying to target and tailor our healthcare around the individual that's in front of us, and understanding that baggage, even if it's not something that we necessarily feel ourselves.
And the other important thing, I think, that Duke said, which really does, I'm doing quite a lot of work on the COVID vaccination programme, where we're linking in with communities that don't often engage with the NHS. And that bit about, you know, Black men not wanting to see white doctors, I think that's where we need to build a trust with communities, so that, you know, that opens the doors rather than closes the doors. Okay, so part of what we're trying to do in the Cancer Alliance is to raise the awareness of the risks of prostate cancer and what can be done about it. Ed, do you want to talk a bit about the plans the Alliance have got to try and improve the detection and then the outcomes for prostate cancer?
Yeah, so I mean, I think COVID has been a big reckoner for early diagnosis for us. I think sort of if we take the number of operations we did for prostate cancer pre-COVID and compare them to now as a sort of indicator of what's happened. Pre-COVID, we probably did 300 radical prostatectomies for prostate cancer in the year up to 2019. And I think probably throughout COVID, in the past 18 months, our numbers have probably dropped to around 150-ish. So, you know, we're probably doing half or you know, around half probably of what we were seeing pre-COVID, and that's largely because, you know, patients haven't been able to present to the clinic for one reason or another. We're seeing a slight rise in that, so hopefully that is coming back, and I think there are a number of barriers to the patients coming forward, some of which is COVID fear, some of which is, you know, struggling to get GP appointments for whatever reason, And then obviously the usual concerns about, you know, not wanting to come forward because of all the tests that may ensue. So because of that, we sort of tried to look at developing a straight to PSA test for men that are interested and concerned about their prostate health, which will hopefully be launching in the next few weeks in Southampton, which will mean that a GP won't need to refer a patient, they can refer themselves. There'll be an email link which the patient can send an email, they'll get some information. If they want to proceed to the test, we'll then arrange for them to have the PSA. And obviously, listening to what Duke said, and obviously it's a cause for concern for us as well, is how do we encompass all of the patients that we might need to get in that, so those that aren't IT literate, etc. And we're looking at developing that as staff members come online. So, you know, hopefully watch this space and we will have multiple channels of communication to make that happen.
Okay, so self-referral has been tried in a number of different spheres, and I think it has its advantages, but often I think the concern is that the worried well come forward and we don't get to the people who really need it. So whatever we do in terms of communication to the community, and I think that's where Duke's comments are really quite powerful in terms of what we've got to do. And presumably that's where the football clubs have been quite successful in the people coming there and the fans and getting the messages through them, Duke?
Yes, so I think it's Sue Newell.
Yes.
And Dr. Richard Rope.
Yeah.
So on Wednesday, I have an inclusion forum, which I meet all the community leaders in the city every 2 to 3 months. And we sit around the table and try and work out how, for one, how we're going to diversify the fan base, two, to network with each other. So we're talking the Sikh community, LGBTQ community, refugees, African community, women and men. So we have Kurdish community. We'll all come together and try and diversify the fan base and get included in what we do at Pompey in the community. So Sue and Richard are coming down this Wednesday, and I thought it was really important that they come down, give a little info session for about 20 minutes, maybe give out some leaflets or something like that, so my community leaders can then disseminate that information out to their community. And that's what I've been doing for the last 9 months. So I have community leaders that have never been to a football match, so I invited them, and they had a brilliant time, because a lot of the time they're intimidated by the fans, they're intimidated by the white fans, especially because they're of colour, so they automatically think they're not welcome. So Marie Costa, who represents African women, she's in her 70s, she came to a match, thoroughly enjoyed herself. Thought, oh, what was I so worried about? However, and that's what I'm hoping to do, is to use that information, disseminate it down into the local community, and get the word out there, and just keep doing that.
But the key question was, when they came to the football match, did Pompey win?
What match was that? That was the Bolton game. Yes, they did. Yeah, 1-0.
So that made it more enjoyable then.
Yeah, 1-0. Yeah, it's like, phew. But that took some doing just to convince them to come along to a match. So if you can get through to one person who's really engaging with the PSA or the MRI or the DRE and thinks it's really, really good, that's the person we need to concentrate on to disseminate that information.
And that's the disseminated information coming from a trusted source.
Yeah,
so there's lots of recent evidence that looks at where people, if you take COVID, for example, where people have taken their information from, and it's not always from NHS sites or what healthcare professionals, it's what their friends have told them and they've discussed. So, you know, getting messages to community leaders and having community leaders on board and sharing that information is probably the most powerful way of getting those clear messages out.
That's how my dad got the information. He got prostate issues. He's 79 now, and he was diagnosed when he was 74, and he didn't even know. And it was a Rastafarian woman that he was talking to in the UK about prostate cancer. Then he went and got it checked, and he's had it since. He's got the highest respect, let me tell you, for every healthcare worker in this country. But he feels that the Jamaican community are very ignorant, and in his own words, illiterate, uneducated, don't want to know. They're too wrapped up in themselves, homophobia. But my dad now is on the mend. He's having his injections and his treatment, but he has high regard for the NHS and all the health professionals. So my dad is another advocate for telling other people as well, you know. And it scares him. It's scaring the life out of him.
Sure. Ed, what about, Duke's talking about injections. What about treatments nowadays? What have they changed? Keep it very simple, because remember the audience are GPs and practice nurses.
Yeah. I mean, without going into too much detail, you name it, you can pretty much do it to the prostate. In terms of prostate cancer, so there are some less invasive treatments that we don't quite know the longer term cancer outcomes, but certainly they have less in the way of side effects. The historic incontinence, erectile dysfunction issues that we see with conventional surgery and radiotherapy. So one in particular called HIFU, so high intensity focused ultrasound, or cryotherapy. There's various studies ongoing looking at those at the moment. And then even surgical techniques have improved. So, 10 years ago, most places weren't using a robot. Now pretty much everywhere uses a robot. And I think we can see better recovery in terms of continence and erectile function, and patients just getting up and about. And then with radiotherapy, again, there's, they can focus the beams a lot more closely on the prostate. Lately, we've sort of started putting rectal spacers in, which lifts the prostate away from the rectum, and so minimizes the impact that the radiotherapy might have on the rectum and some of the side effects and toxicities that way. So it's all evolving every day, basically.
So I have fond memories of being a urology houseman and spending hours in theatre doing radical prostatectomies, which you probably don't do anymore.
We definitely do. We still do them, but we do them with a robot.
So for the older doctors like myself who haven't seen the robots working, what's the advantage of doing using a robot rather than a skilled surgeon like yourself?
Well, you need both, I think, is the key. So the benefit is you can do it minimally invasively, so no big operation, no cut from the belly button down to the pubic bone. So 6 small holes, and compared to conventional laparoscopy, the main benefit is that the instruments are wristed, so you can sort of get into tight spots down in the pelvis, and you've got a 3D picture, and so basically it makes everything a lot better without wanting to get into too much jargon.
Okay. The consultant I worked would have said that was a small incision. He'd have gone well above the umbilicus.
Right, there you go.
Get good access to the prostate. Yeah. Okay, so what could we do as practices to help? So I think listening to what Duke's got to say and what Philippa and Ed have got to say, I think being aware of the raised risk in people who've got a family history, how often do we ask for a family history of cardiovascular disease or diabetes, but do we ask, have you got a family history of prostate cancer? So that's one thing. Second is being aware of the increased risk in Black Afro-Caribbean. I think what Duke was saying about culturally thinking about how people access this and how providing information to them in ways that they would receive it rather than in ways we think people should get it. Also, when you're looking in a practice, you could actually look at your database and search those people who you potentially think are at high risk. So doing some proactive identification. But then I take on board what Duke said. Don't then send a letter to them to say, we think you might be at risk of prostate cancer. Please, could you come in for a blood test, digital rectal examination, then we'll do some fancy investigations on you. That's probably not going to get most people coming rushing in to make an appointment. And I know some practices have got patient participation groups which are quite active in having meetings with patient groups. I think the sort of thing that Duke's doing in the community, and I know the Alliance are doing through Soon Yule and the patient engagement, I think all those things about raising the awareness and multiple channels are really important. As we come to a close, I'm going to ask you, Ed and Philippa, for 3 hot tips for GPs and nurse practitioners and others, because it's not just GPs who see patients. There are a wide range of the primary care team. But I'll come to you, Duke, first. What key message would you want to give to GPs about prostate cancer and the what you think we should be doing better than what we're doing now?
Well, I think if you are talking to a Black or Jamaican or African man, be proactive and mention it. Even if they've come in for something else, mention it. And that they can go away and think about it. Or maybe you can have a little short survey about the family history, a little 10-question survey, put prostate cancer in there. Once they've done the survey, then ask them if they know anything about prostate cancer. Simplify it so it's not too scary. So I would ask the GPs, when Black and African, Jamaican and African men come in for whatever they come in for, ask them the question. Do you know anything about prostate cancer? Is there any prostate cancer in your family? As simple as that. Every single person that comes in.
Okay, Philippa, what would your 3 key tips be?
I think if a rectal examination is going to be a barrier to even get the man to have a PSA test or to even come in and talk about it, then don't feel wedded that you have to do it every time. As Ed said, it is part of the puzzle and it is useful and helpful. But if it's don't do a DRE and get to see the man, or do a DRE and then he'll never darken your door, then I would say don't worry about it and just refer them anyway. And I think trying to be proactive about asking and speaking to men. We know that this population has a high risk for diabetes and for hypertension, for an example. And so I'd really want to encourage practice nurses who are very often doing the maintenance and long-term follow-up of men with diabetes or with hypertension, etc., that actually they are proactively asking this patient group as well. Talking about urinary symptoms and prostate normal, that it isn't anything to be embarrassed about. My experience is that men actually don't mind talking to women. Some of the Arabic men are more stilted talking to women than they are to men. But I think we are health professionals and communication is a big part of what we do. So I'd really want to encourage the nursing staff to make the conversations count when they're seeing men anyway.
I think this is key is actually in the when we're doing health checks, which aren't usually done by the GP. I absolutely agree with you. The practice nurses, I think when we're doing those blood pressures, all the other things, cancer should be brought up at particular ages. When you've got 50-year-old men, potentially just mentioning that. I think also it's not just talking to the men about it. Dare I say that quite a lot of men are heavily influenced by what their spouses say. So I know in my experience quite a lot of men have come in to see me because it's their wives who've suggested they come in, and they've come in rather reluctantly. But once they've broken that sort of ice and they feel more comfortable, then I think that's absolutely fine. So I think that's really key. The other bit is
So I would also say that let us be optimistic. Prostate cancer is a cancer. There is a very much I've got cancer equals dying painfully, and prostate cancer, as Ed has outlined, there are a lot of really safe, effective treatments for prostate cancer, early prostate cancer, particularly. So we've got curative treatments for men with early prostate cancer. But even if we look at the other end, for men who are diagnosed with advanced disease, when I first started working in prostate cancer, we had castration or injection therapy, and that was it. And now we have a whole armory of drugs, don't we, that we can use when the primary hormone manipulation starts to fail. So there are lots more things in the cupboard. And I think I see now a relationship between urologists and oncologists that wasn't there 25, 30 years ago, but it is there today. And I think that's really brilliant. There's real multi-disciplinary and multi-professional working to find the best treatments for men. So I think we can be really positive and change the narrative.
Yeah, that's really key. I think that's a point really well worth making, because I agree with you. I think when you talk to patients, that as soon as you mention the possibility of cancer, you can just see the look on their face, which is, you know, well, that's the end, isn't it? Rather than, you know, what we're aiming to do. And prostate cancer, absolutely agree. You know, you know, I can remember as a urology houseman exactly the same as you, and that's probably even before some of the hormone treatments were around. Ed, what would your 3 key bits be?
I think yeah, it's difficult to follow that. That was some pretty key 3 bits, but I think for me it's about the opportunity. So often men come with LUTs and, you know, so low urinary tract symptoms, and that presents an opportunity to do a PSA to sort of talk about that in terms of not only their prostate cancer risk, but also for us is useful in determining what kind of treatments we might think about for their low urinary tract symptoms. So you kind of get to kill 2 birds with 1 stone, if you like, because the PSA can help predict risk of retention, etc., down the line, just from that point of view. I think I would agree with Philippa. You know, the DRE, certainly the 2-week wait pro forma in our area doesn't recommend or doesn't demand that you have that, although I think in the Isle of Wight it might. We've sort of had some discussions about that as we're sort of leading up into this webinar, and I think, you know, it's one of those things. It's all about patient choice, and no decisions about patients without them. And, you know, if a patient came to me and said they refused the DRE and there was enough concern, then we might go straight to an MRI. You know, it's all about patient choice, I think. And then the third thing really is, I think historically a lot of GPs, in my experience, have sort of perhaps misunderstood the PSA, or perhaps urologists have misunderstood the PSA. And it's not a great test, but alongside MRI scans and prostate biopsy, actually we can now make really accurate diagnoses and avoid the harms of treatment in some men, whilst treating those that definitely need treatment. So I think the landscape for screening is changing and evolving. And I think in sort of 5 to 10 years time, we might have a more similar to sort of breast cancer screening program that's introduced for prostate, although, you know, I don't have a crystal ball, but I would potentially predict that.
Yeah, I can remember actually sending people off for a PSA, because I know it's probably wrong, but if you did a DRE before the PSA, it was at one stage they thought it might increase the PSA. So we used to do the PSA first and then they would come back, which actually did mean that you got a pretty good idea with the PSA, and quite often they didn't need a DRE because they refused it. I've certainly experienced that. So they're all very good tips for GPs and also for practice nurses and other parts of the primary healthcare team who this is really important, and actually to share the message. And there's probably some good messages there for us in the Cancer Alliance to take forward. So can I thank Duke, Philippa and Ed for their time today. Hopefully, if you've watched this, you found it useful. And we'll make this widely available to whoever is interested in learning a bit more about prostate cancer. Thank you all very much.